Good evening, everyone. Once again, I'm immensely honored to welcome all of you to the International Lecture Series on Clinical Nutrition. Today, we are on the 5th session, and we're really overwhelmed with the response that we've got from all the participants. We also hope that you're making the most of all the sessions and attending the entire sessions as well. We welcome you on behalf of Clinical Nutrition Excellence Academy, Hexagon Nutrition Limited, Indian Dietetic Association Mumbai chapter, with academic partnership with Kenya Medical Training College. Last week, we had a wonderful session by Dr. Anagha Palekar on enteral nutrition in critically ill conditions. Now, hypercatabolic states, as you know, are associated with an increase in catabolic hormones, which in turn decreases the muscle mass and increases the risk of malnutrition in surgical patients. This is associated with poor outcomes, poor surgical outcomes, and therefore nutrition pre, peri, and post-operative patients is extremely important. In fact, the ESPN guidelines suggest early oral feeding for surgical patients can improve the outcomes in terms of improve the outcomes for surgical outcomes for the patients. It will improve the length, decrease the length of hospital stay, decrease the risk of infections as well. So today we have one such speaker who will be speaking about enteral nutrition in hypercatabolic conditions with focus on surgery. Now, before we begin with the session, let me just quickly reiterate the rules and regulations. Certificate of attendance will be given to all those who attend all 10 sessions, followed by an objective test. Attendance for all the sessions is mandatory, and you need to attend the entire session. Objective test will be 100 marks test via a Google form, which will be sent to you on the 1st of March 2023. Minimum 80% attendance is required to pass the test. Feedback for all sessions is mandatory. Feedback link will be posted at the end of the session. The feedback link for the first 4 sessions was posted in the chat box. Some of you have emailed us that you have not received the feedback link. We'll be posting all the feedback links at the end of the session today. So please make sure that you copy those and save them with you. Questions can be posted in the Q&A box and will be taken during the panel discussion. Any other comments, suggestions that you have, kindly please post them in the chat box and not in the Q&A box. Those attending from the YouTube link will not be eligible for the certificate. So I welcome you all for this session on enteral nutrition in hypercatabolic states. Our speaker today is Ms. Safala Mahadik. She's a senior dietitian with KM Hospital in Mumbai. Ma'am has immense experience in a government hospital for about more than 30 years. She's a PG and RD and certified keto epilepsy dietitian with Asian Institute of Ketogenic Diet Therapy. She's an LEC member with Indian Dietetic Association Mumbai chapter. She's also a certified member of Metabolic Dietitian Group in India. She's conducted various lectures and has been featured on Doordarshan TV. Also co-authored various research papers and projects on dietary effects on various disease conditions. So I welcome you, ma'am, to give your today's lecture on nutrition for hypercatabolic states.
Can you all hear me?
Yes, ma'am.
Yeah, one sec. I'll just share the screen. Can you see my slide?
Not yet, no.
Now?
Yes, we can see it.
I'll just make a slideshow.
Yes, ma'am. Thank you.
Okay. My greetings to one and all present here, and thanks Sukada for a kind introduction and also for making me part of your this nutrition talk series. Today I'll be covering under this headline of catabolic state, I'll be covering surgery, basically nutritional aspects in general surgery, pre and post liver transplant and cardiac surgery in next 40 minutes. So let's begin with the main aspects in general surgery. underfeeding and malnutrition. These are the major risk factors for post-surgical complications. And as just now Sukada said, that early enteral nutrition support is most clinical relevant for any surgical condition. So to improve outcome and shorten the hospital stay. ERAS protocol's main component is nutritional management, and his metabolic strategy is to prevent, to improve outcome by reducing the perioperative stress. So rehabilitation program of ERAS is a tri-modal approach, including nutrition, physical exercise, and stress-reducing psychological component. Nutrition plays a key role in all the 3 stages of surgery. Now, as we talk about preoperative. The preoperative nutritional main component in nutritional management is preoperative nutrition counseling, preoperative optimization of nutritional intake, and very important is avoid fasting by carbohydrate loading. There is absolutely no evidence to support that if any patient is taking clear fluids up to 2 hours before any elective surgery, then there is a greater risk of aspiration as compared to traditional long hours of fasting. Because this carb loading usually suppresses the metabolic disturbances like insulin resistance. It improves post-operative cardiac function. It also enhances the post-operative patient's comfort and shortens the hospital stay. Secondly, this one more thing I would like to tell you is this clear liquids empty the stomach between 60 to 90 minutes. So it will not be, it will be already out. So there is no problem of aspiration will not occur there. And secondly, if we are keeping it by traditional method of keeping fasting for 10 to 12 hours, then what will happen is glycogen will get depleted and gluconeogenesis will get upregulated. So even before surgery could begin, that metabolic stress will get accelerated. Post-operative oral or enteral route should be always preferred. If not feasible within a few days, say 4 to 5 days, then tube feed needs to be initiated. Initiating ONS is the best, and inadequate oral or enteral route. Suppose then it has to be it will be a greater, it will cause greater morbidity. It will be a greater risk for morbidity. So regular nutritional assessment is mandatory at every step. Perioperative we will see in detail in next slide. So correction of undernutrition before surgery and maintenance of nutritional status after surgery, it helps in reducing mortality, morbidity, and length of the hospital stay. Perioperative nutritional support should be initiated from the preferably by enteral route or oral nutrition supplement. If not feasible, then tube feeding. Word of caution, enteral route should not be preferred in cases of intestinal obstruction or ileus, severe shock, intestinal ischemia, high output fistula, or severe intestinal hemorrhage. If less than 50% of requirements of calories and proteins are being met enterally or orally in next 5 to 7 days, then initiation of supplemental PN is required in combination with enteral. And what we call is that as dual nutrition. Now this flow scheme, gist of this flow scheme, which is based on the guidelines, it says that preoperatively, if patient is extremely malnourished, then nasojejunal or nasojejunostomy feeds needs to be considered. If preoperatively patient is malnourished and postoperatively it will not be taking orally for next 5 days, then dual nutrition should be thought of and is already recommended by all the guidelines. And post-operatively, patient has to, they have to start post-operatively clear fluids at the earliest, if with special caution with the elderly population. Then if oral fluids are not possible, then tube feed needs to be initiated. Guideline says at a slow rate of 10 ml to maximum 20 ml per hour, and then go ahead with the target volume. But in my setup, as my experience in the hospital, we, for adult surgeries, we start with the 30 cc trophic feeds every hourly, 4 feeds. Then after 1 hour gap, we do check intestinal tolerance or any aspiration. And then we, from the lower volume, we start initiate the feeds till the target is reached. Sometimes because of the intestinal, some clinical instability or intolerance, it might take to reach target goal, might take 2 to 4 days to get the target calories and proteins. But we need to start at the earliest. Secondly, in most patients, whole protein formulas or polymeric formulas work best. Sometimes high calorie, high protein formulas also will be required. Guidelines recommend not to feed home feedings, or kitchen feeds are not indicated as due to risk of microbial load or tube clotting. But setup like mine, where we need to consider the financial constraints very much, and then we definitely use homemade feeds or kitchen feeds. Of course, they are prepared in very hygienical conditions, along with formula feeds are given. Then secondly, formula rich in immunonutrients, like, which is comprises of glutamine or omega-3 nucleotides and all that, arginine. So this immunomodulating feeds are kept reserved only for the extremely malnourished patients. Those are major cancer surgery cases. Otherwise, we use basically we start with polymeric formulas only. For those surgeries where brain injury or head and neck surgeries, where long-term use of tube feeds are required in long term, then PEG insertion is recommended by all the guidelines, and we do apply that in our system. Secondly, if patient is not adequately fed, then sometimes for gut barrier function, parenteral glutamine is initiated, but that is very rarely has to be used. All these immunonutrients like glutamine, omega-3 fatty acid, arginine, these are in all they have a potential in reduction of hospital stay and morbidity. Also, it reduces if you are using these immunonutrients, but there is no clinical evidence so far for the sole use of this all immunomodulating substrates. Basically, in various cancer research RCTs, major cancer surgeries, I would say, they have given the substantial use of all these immunonutrients, but still it is under trial, and many robust evidence is still required to support this. Moving on to pre and post liver transplant. Liver is the most largest and most crucial metabolic organ, as you all know, and it has it is what we can say, it plays a very pivotal role in integrating several biochemical pathways of carbohydrate, protein, fat, vitamin metabolisms, then transport of lipids, secretion and excretion of the biles, and all these are associated with muscle and protein metabolism, and is very much required for the well-nourished status. In many of the ESLD conditions where PM is protein energy malnutrition, which is seen very often significant complications, in those patients we are awaiting for the liver transplant. It is more likely seen in decompensated liver disease with ascites, hepatic encephalopathy, portal hypertension hemorrhage, or alcoholic liver diseases. And if it's not treated on time, then it predisposes the patient to complications such as compromised respiratory function, delayed wound healing, longer reliance on the mechanical ventilation, increased septic complications, thereby increase of heavy antibiotics, and increased length of the stay, with delayed physical rehabilitation, and all of which substantially leads to higher transplant cost. Therefore, pre-surgical nutrition is a priority. So aggressive approach to nutritional repletion and correction of micronutrient deficiencies is central for maintaining hepatic function, improving the patient's metabolic reserves, and improving outcomes following liver transplant. If patient's nutritional status deteriorates significantly in the post-operative period, then it can be due to perioperative malnutrition, post-operative protein catabolisms, surgical stress, immunosuppressives, and post-interventional problem, and mainly long fasting intervals. This shows that there is urgent need for preventive dietary assistance in the form of liver-adapted formulations, comprising with more carbs and lipid protein in proper composition, and particularly branched amino acids. Now, what is the etiology of malnutrition in this ESLD cases? Mainly, very important is decreased calorie intake. Then it happens because of anorexia, which is caused by zinc deficiency, hyperglycemia, and increasing pro-inflammatory cytokines. Some patients might have H. pylori infection, which is causing dyspepsia, and it lacks a desire for food because of that infection. Then lack of appetite because of unpalatable diets. Sometimes they have, we need to give low salt or low protein, especially in hepatic encephalopathy patients. Then altered taste sensations, which is caused by hypomagnesemia and autonomic neuropathy. Early satiety is due to tense decreased GI peristalsis. Due to GI bleeding, there are increase in protein losses. On worsening all that, on top of it, there is a bacterial overgrowth and also protein losing enteropathy, which is seen along with this. Then second point is decreased nutrient absorption, which is due to drug-induced diarrhea, fat malabsorptions, and due to various surgeries and GI reperfusion injury, immunosuppressors like corticosteroids, which delays bowel function recovery. And third and very important, it's hypercatabolic status. When there is an increase of basal energy expenditure, which increases sympathetic nervous system activity, along with inflammation, fever, peritonitis, and bacterial translocation. Insulin resistance causes much metabolic derangement, which leads to acute muscle depletion and decrease in subcutaneous fat. Same time, there will be IGF-1 decrease, which mediates further increase in growth hormone resistance. Therefore, accurate nutritional assessment of nutritional status and precise intervention are the prerequisites for perioperative treatment for patient undergoing liver transplant. Traditional methods of BMI and simple normal anthropometry will not be accurate in the cases of this LT because of fluid retention many times and also organomegaly. So main points to be focused on: physical and clinical examination, then subjective global assessment, which gives us overall, we come to know by various aspects. In SJ, we know detailed study of, we can have a proper status, what at stage of malnutrition that we come to know from by this tool. Then biochemical parameters, routinely they will be doing like CBC and renal function test, liver function test and all, CRP. But along with that, reduced levels of transferrin, albumin and transthyretin, that is pre-albumin. These are the markers of malnutrition. This needs to be checked. Then hand strength dynamometry, which is a good reflector of the upper limb strength. Then those setup where bioelectrical impedance analysis is possible, where it is definitely useful to quantify undernutrition in spite of limitations in patients with acidic decompensation. The main aim of the liver transplant nutritional therapy is to preserve nutritional and muscle from depletion, then to correct vitamin and mineral deficiencies so that we minimize the risk of infection and debility. So energy is more than or equal to 1.2 times basal energy expenditure. That can say 25 to 30 kilocalorie per kg per day. And see here, I would like to tell you one thing is ESPEN recommends in all organ transplants guidelines, it says that as we say, early enteral support is of prime importance in this. Here, I think because of that, justified enteral nutrition always stimulates, gut-associated lymphoid tissues. Antigenic stimulation of gut-associated lymphoid.
Can we go a little slow?
Sorry. Yeah, I'll try. Enteral nutrition, enteral nutrition predisposes antigenic stimulation to the gut-associated lymphoid tissue. It also, increases a biliary secretion of the immunoglobulin A. So both these factors are very important as a barrier for translocation of the luminal bacteria, and thereby we are preventing complications, infectious complications mainly. So we need to give enteral support as early as possible. Secondly, proteins, as we say, minimum to start with 1 gram per kg body weight so that we can maintain the positive nitrogen balance, and thereby we can go progressively up to 1.5. Sometimes it can happen that we need to give up to 1.8 to 2 gram in severely malnourished conditions. Wherever possible, we need to include branch chain amino acids, and whole protein formulas are appropriate in this. Secondly, carbohydrates intake should be provided from the complex carbs. 50 to 60% of non-protein calories requirement should be met by complex carbs, and it takes a protein sparing action. It does a protein sparing action. If glucose required, then infusion should not exceed 2 to 3 gram per kg body weight per day, because excess glucose can cause hyperglycemia. It can lead to lipogenesis or excess carbon dioxide production. Fat is a very important micronutrient as a concentrated source of calories, and unnecessarily need not be restricted unless malabsorption is diagnosed. We need to give as per the requirement, like, what we suggest, we give here is visible fat as 25 to 30 grams maximum per day. We incorporate MCTs because MCT is a one thing which is a concentrated source of calories, and secondly, it doesn't require bile salts for absorption. And there is no if it is specific, there is no specific tool as such to determine malnutrition in these cases. Whichever according to a setup and whichever according to the patient's clinical condition, we need to implement that before prescribing any nutritional regimen. Now, little information about branch and amino acid supplementation. As I said before, this BCAA supplementation, usually it is selectively used for hepatic encephalopathy patients. But there are many, recently I've seen studies which shows that pre-LT BCAA enriched formulations have been shown to reduce ammonia. It improves albumin, pre-albumin levels, total lymphocyte counts, then BTR ratio. It improves on glucose tolerance. It helps in liver regeneration and immune system function. Also, it improves in dendritic cell maturation and therefore prevents post-operative sepsis. Now, in this case, one BTR ratio, this I would like to tell you some little about it. This BCAA to tyrosine ratio is usually, it has to be 3.5:1. But in ASLD condition, it falls below or up to 1:1 condition, 1:1. What happens is when it falls below to 1:1, then it gives access to aromatic amino acids, and then it transports across the blood-brain barrier, and then false weak neurotransmitters are converted into false weak neurotransmitters, which competes with the endogenous neurotransmitters, and then it further affects brain by inhibiting excitatory stimulation of the brain. Thereby, hepatic encephalopathy is further worsened. Along with that, same time, tryptophan also converts into 5-hydroxytryptophan and further induces more lethargy. So it's very important to normalize BCAA to tyrosine ratio in this condition, and which helps by BCAA enriched formulations. These are the micronutrients which are usually gets affected in this procedure, in this ESLD conditions. That is in thiamine and antioxidants, selenium, vitamin C, vitamin E, folate, B6, magnesium, and calcium and vitamin D. So because of all this, see, these micronutrients, if they're affected, we need to give vitamin and mineral supplementations. But as a nutritionist, I would say that whenever we are pre-LT, when we are planning any or executing any plan, we need to consider these vitamins always, and all dietary sources, rich dietary sources of these micronutrients need to be incorporated in our diet plan in such a way that any side effect of this micronutrient deficiency will not occur, and it will be post-surgical outcomes. There are also studies showing about importance about immunonutrition. In many meta-analyses that shows that immunomodulating diet comprises of glutamine, arginine, omega-3 fatty acids, nucleotides, which are enriched with hydrolyzed whey protein, they have proved to decrease post-liver transplant bacterial infections. It inhibits production of inflammatory cytokines, and it decreases the incidence of post-LT hyperglycemia. This can be because of isomaltulose disaccharides that helps in reducing that hyperglycemia. Secondly, symbiotics, which is a combination of probiotics and prebiotics. This it enhances the immune system, attenuates the systemic post-operative inflammatory response, modulates lymphocyte function, and initiates immunoglobulin production. As I said just now, that immunoglobulin A, which helps in preventing it from the bacterial infections, thereby we can prevent any type of surgical complications, restore macrophage functions, and overall it decreases the occurrence of post-liver transplant infections and reduces duration of antibiotic therapy. In our setup, we do use the symbiotics or even plain probiotics, oral, enteral, or parenteral. Wherever the cases according to clinical condition, we do use this, and we have seen a very good results with this symbiotics. Especially for reducing inflammatory condition, it's of real importance. Physical rehabilitation is of real paramount importance, and if not done on time, then adverse effect of this physical inactivity and bed rest may not only worsen the complications of reduced functionality, also muscle wasting, osteopenia, which is all linked with the decreased post-liver transplant success. So physical rehabilitation also is prime importance. Additional points to remember is reduce salt intake to 2 to 3 grams per day, avoid periods of long fasting, provide small frequent meals to combat catabolic state, and late evening snacks with the carbohydrate and BCAA, which helps in improving protein metabolism, lipolysis, and also improves serum albumin and pre-albumin levels. Moving on to post-transplant aspects, the main principles will remain same, which we have just now discussed about pre-LT. But additional, the goal of the nutritional therapy in the acute post-LT phase is to ensure adequate protein and energy provisions to avoid protein breakdown. Energy starting intake can be 1 to 3 days is 10 to 15 kilocalorie per kg, and gradually needs to be increased up to 25 to 30 kilocalorie per kg. Initial infusion rate should be 20 ml per hour. Once tolerated, then we step up to 40 ml per hour. Polymeric formulas are appropriate for this, and also it should be high calorie and high protein. Protein, as I said before, we need to start minimum of 1 gram per kg body weight, and to maintain the positive nitrogen balance. And sometimes we need to go ahead from 1.5 to 2 gram per kg body weight, depend upon the patient's clinical condition and tolerance, its hemodynamic, its stability. So many factors are associated with all this. Resuming enteral nutrition within 12 hours of LT helps to reduce post-operative viral infections and improves better nitrogen retention. Salt intake, as I said before, 2 to 3 grams per day to prevent water retention associated with the steroid therapy. Hidden sources of salts and flavoring agents should not be promoted. A pharmacotherapy, which is a part and parcel of the liver transplant plan. So there are many immunosuppressive therapies which are used for this LT, like corticosteroids, cyclosporine, tacrolimus, glucocorticoids. All these immunosuppressants have their own various side effects. Like impairment in muscle growth, or many of them has diabetogenic potential. So it can cause increase in glucose intolerance. Then new onset diabetes can start, or there will be muscle loss will be seen, skeletal muscle loss, depletion also seen. Weight gain is very common. Osteoporosis. Sometimes some patients, they increase appetite later on. So they, to combat with this all condition and to improve the at the earliest and get into recovery phase, what we have to do is, before executing any plan, we have to completely, we have to always remember all this pharmacotherapies in perfect in the mind with the side effects. Because while executing any plan, we have to, uh, you know, change their micronutrient composition, alter the such a way that we minimize the side effects as much as possible, with all, so that they will not be having any such hyperglycemia or unnecessary weight gain. So we will be taking care about a composition of macronutrients along with micronutrients so far, so that, high fiber diet will increase properly food, all good amount of fruits and vegetables, sprouts will be used in space out properly way throughout the day, good quality, high quality protein along with formula feeds. We'll be using high biological value proteins to prevent muscle loss. So there's so many things we have to keep in mind throughout the acute and chronic phase of post LT. One more side effect is seen, what is hypercalemia. Sometimes we have seen nephrotoxicity in these cases due to immunosuppressants. Watch on the electrolyte labels, and accordingly we need to change our dietary pattern or whatever. Suppose, for example, we have seen the potassium is label, serum potassium is in the higher side, then definitely we need to make changes accordingly. Like leaching of vegetables or potassium resources not should be avoided. So accordingly, we need to give instructions as per the condition in front of us. Neutropenic diet, you all know about all these instructions, but to list a few, avoid stale foods and raw foods. Care to be taken always about contamination in food handling. Maintain good hygiene and sanitation practices, and this has to be throughout maintained up to till the corticosteroids or immunosuppressors are continued in this treatment. To summarize this, patient should be motivated to follow diet which promotes a healthy body composition, which is and low in fat, adequate amount of lean proteins, especially high biological value proteins to be considered to improve muscle loss, sufficient calories to spare proteins and being used for energy, complex carbohydrates and micronutrient supplementation as per clinical condition. Most importantly, routine follow-up with the dietitian during transition from acute to chronic post-transplant is mandatory. Moving on to the next topic is nutritional therapy in cardiac surgery. See, nutritional therapy now is increasingly recognized as most clinically relevant in patients undergoing cardiac surgery. Here, I am more emphasized upon various valve surgeries like aortic valve replacement or mitral valve surgeries, or even double valve surgeries sometimes are needed. Then secondly, cardiopulmonary bypass, CABG surgeries, grafting surgeries like. So where we are more focusing on. So nutritional support and adequate nutrition, these are all crucial factors contributing to the outcome of these patients. Now, while addressing these problems here, mainly what we have seen in cardiac surgery setup is systemic inflammatory response. Systemic inflammation is highly triggered with various ways in cardiac conditions. So patients undergoing cardiac surgery, they experience this systemic inflammatory response, which contributes to organ damage if not taken care, which manifests as pyrexia, tachycardia, leukocytosis, hypotension, and eventually organ failure. There are several stimuli leads to this systemic inflammatory reactions. Mainly, first is the surgical trauma, which induces the activation of neutrophils, endothelial cells, and activation of release of mediators. Then the next is foreign surface contact during cardiopulmonary bypass, which leads to activation of cellular components such as leukocytes. Then during cross clamping of the aorta, the reoxygenation of the tissues, which further triggers sometimes this inflammatory response. Then hemodilution through this large extracorporeal circuits and blood loss during surgery often creates a need for blood transfusion, which can further trigger this inflammatory response. Then bacterial lipopolysaccharides from gram-negative bacteria may induce cytokine production, complement activation, release of nitric oxide, which all these factors further contribute to extent of organ dysfunctions. So this way, there are so many factors which are associated in cases of how that the inflammatory response can get triggered. So most frequent organ dysfunction, what we have seen in 1/3 of the cases is pulmonary, ventricular, or cognitive dysfunctions, and AKI in some cases. So preoperative nutrition plays a crucial role to prevent worst outcomes post-surgically. The pre-existing malnutrition gets further aggravated by excess preoperative fasting and post-operative delay in nutritional support. That's why all the guidelines, SPAN, all the guidelines recommend prompt nutrition support to combat with the catabolic status. Nutritional support improves the recovery of the patients in various ways by maintaining the metabolism, controlling the catabolism, maintenance of gut integrity, and improving wound healing faster. So the assessment of preoperative nutritional status is of prime importance to consider early nutritional intervention prior to surgery for patients at risk of postoperative complications. So there are the various tools here, what I have just mentioned here. So according to our setup and clinical, what kind of surgery it is, and you can we can use these tools. Every tool gives us relevant information to see the to determine the malnutrition. For example, I'll say that suppose the valve surgeries are there. Usually, rheumatic heart disease, which leads to AVR or DVR or even MVR, these patients are usually very much malnourished. So for them, MNASF, MST, then MUST, sometimes even HGA goes well, and we get a correct information about their malnutrition status. Then for bypass surgery patients, we should use HGA or even Nutric score. Patients who are admitted in the ICU, definitely NRS 2002 is the best to assess the nutritional status. And also it depends upon the acute and chronic condition. Suppose the preoperative patients are better stable, then even SGA will be better option. For very much malnourished status, then MNA or MST or MUST should be used. And in ICU, NRS has to be seen. Secondly, these tools, have specific parameters and which gives us correct information, all that. On top of it, along with that, we will relate with their biochemical parameters. We will see about their blood parameters like, interleukin, CRP, alpha, NF alpha. So all these factors also will be associated. We will correlate those along with this tool, and we can properly counsel and motivate these patients for the next our diet plan, which we'll be executing. SPAN and ISPAN recommends initiation of enteral nutrition within 24 hours after surgery, and supplementation of minimum 25 to 30 kilocalorie and proteins 1.5 to 2.5 grams per day body weight for cardiac surgery patients. Now here, this protein, if I say in bypass surgery, usually they are land up from the ischemic events like, ischemic heart disease, coronary artery disease, which further, because of that blockage, which is not cleared by PTCA, angioplasty, those are selected, those are transferred for the bypass surgery case surgeries. For them, up to 1.33 to 1.5 kg body weight per day proteins will work, but those are extremely malnourished, which I told you about various valve surgeries. They might require from 1.5 to 2.5 grams per proteins per day for their early recovery. Polymeric formulas work best for all the patients. Iatrogenic malnutrition also, sometimes there is a risk in delaying the nutritional support after cardiac surgery. There are no valid biochemical anthropometric parameters recommended by any of these current guidelines for cardiac surgery. Studies evaluating relevance of BMI, albumin, and pre-albumin levels demonstrated that these are independent predictors of morbidity and mortality after cardiac surgeries. Albumin and pre-albumin, they give us incremental information about how long patient will be on the ventilator support, or post surgically any severe infections, bacterial infections, that we get an idea from the levels of this albumin and pre-albumin levels. Though albumin is a marker which takes 20 days for as a half life, but then pre-albumin levels changes within 2 days. So definitely till the next good marker is available, we need to consider this very important markers, I would say, for to check our malnutrition status. Preoperative medical and nutritional optimization is necessary and may provide beneficial effects for major cardiac surgery cases. ERAS protocol may be useful to reduce surgical stress, maintain physiological functional capacity, and facilitate post-operative recovery. Early oral and enteral nutrition intervention diminishes the risk of infection and complications and shortens hospital stay. In our hospital setup, we use polymeric formulas, then the high calorie and high protein formulas specifically. Sometimes we need to use even semi-elemental formulas. Then diabetic formulas are used for some conditions wherever required, and other and remaining high protein formulas. Sometimes we use combinations of polymeric formulas and HP formulas, or diabetic and HP formulas wherever required. SPN guidelines recommend that EN should be withheld until patient is hemodynamically stable, and we do support that, and we do the same at our setups. Polymeric formulas are feasible, as I said before. Circulatory, metabolic, and metabolic responses to EN is adequate during early post-operative course in patients with acute severe circulatory failure. That may be because this EN usually has an ability to preserve that spalnic perfusion. Because of that, those who are at high risk of mesenteric ischemia that EN support will help them to prevent from that. And so enteral nutrition has to be is the best way to prevent those complications. Existing guidelines recommend initiation of PN in critically ill patients within 3 to 7 days if EN is contraindicated or cannot be tolerated with no nutrition risk, and within 24 hours of high nutrition risk. Now, in this case, supplemental PN we do use, but instead of using multi-bottle system, the one single 3-chamber bag is always better to prevent any type of complication or infections further. Intravenous supplementation of fish oil, which is based on lipid emulsions were rich in omega-3, such as EP and DHA, which exhibits anti-inflammatory and immunomodulatory effects. It also lowers the incidence of perioperative atrial fibrillation and in cardiac surgery. In our hospital setup, we do use, as I said before, enteral parental omega-3 supplementation. Even in those are patients are orally, then we do use even oral supplements of omega-3 to reduce inflammation. International recommendations that SPN expert group currently supports the use of olive oil or fish oil in nutritional support in surgical ICU patients, but considers that further research is still required to provide a robust evidence. Glutamine is a one major micronutrient which is immune active substance, which is most abundant amino acid in human body, showing cardioprotective effects in several several clinical trials. So perioperative administration of parental glutamine and enteral forms of glutamine, which leads to reduced myocardial injury as assessed by reduced postoperative troponin I concentration among cardiac surgery cases. But however, many guidelines are not supporting the local routine use of this glutamine, especially parental or enteral, in cardiac surgery setup because of lack of clinical evidence of improvement in cardiac surgery conditions. Selenium is a trace element which is important for many of the body's regulatory and metabolic functions during time of stress. Recently, a randomized control study which demonstrated that safety and feasibility of high-dose selenium supplementation, that is 400 micrograms, 4,000 micrograms in cardiac surgery patients, but no clinical significant clinical effects could be detected from this. Here in our setup, we don't use as specifically selenium as supplement. We have not used, but then multivitamin and multimineral supplementation is already is prescribed in post-surgical interventions. Thiamine, vitamin D, and vitamin C. These three are the important vitamins which are more oftenly researched by in various clinical trials. So it is essential. And then first we talk about thiamine. That thiamine is essential cofactor for pyruvate dehydrogenase function and is responsible for adequate aerobic metabolism. Preliminary studies demonstrated that B1 levels predicts postoperative morbidity and mortality. But however, still robust evidence is still required, and there is no such guidelines are not recommending this hypothesis that B1 administration will lower blood lactate levels and it will improve the clinical outcome, especially in cardiac surgery cases. In our hospital setup, we do use thiamine injectables and or supplements are used. Specifically, they are kept for patients who are having comorbidity additional of congestive heart failure, or those have past history of alcoholism. So we can say alcoholic cardiomyopathy cases where thiamine really works better and it helps in improving outcomes. Vitamin D, it is involved in numerous physiological mechanisms desirable for cardiac surgery cases, such as regulation of atrial stiffness and endothelial dysfunction. In our setup, routinely vitamin D supplementation as such is not given unless and until it is diagnosed to have insufficiency of vitamin D, or if there is any insufficiency or below levels seen, then vitamin D is usually prescribed. Vitamin C shows function in human biology, as you all know, and it reduces oxidative damage, resulting in organ injury in critically ill patients with septic and septic shock. But recent meta-analysis of small preliminary studies demonstrating administration of vitamin C is effective as a prophylaxis for prevention of post-operative atrial fibrillations. And it is really used in many of the cardiac surgery cases, and it works well. So what I feel is, as a dietitian, we need to, while executing any plan, we need to enrich all dietary sources which are rich in all these various micronutrients, rich in antioxidants, which has been proven beneficial on reducing reactive oxygen species and faster recovery. My last two slides are, I don't know whether I have crossed the time limit. Metabolic control and maintenance of normal glycemia, substitutions of electrolytes according to blood work remains the short-term goals always for nutritional support. It has to be adapted to the individual tolerance of each patient. Physical and clinical examination, evidence of gastrointestinal motility, absence of diarrhea, vomiting, and abdominal complaints may serve as a parameters to evaluate the tolerance of nutrition at every step. To summarize, the assessment of preoperative nutritional status and nutritional assessment in high-risk group is must. Post-operative EN should be initiated at early stages in hemodynamically stable patients. Intense nutritional support with adequate energy and protein intake is of relevance for patients who are at high nutritional risk. Clinical significance of oral and EN to be continued after surgery to reduce surgical stress, maintain physiological functional capacity, and facilitate post-operative functional recovery. These are some references, and thank you for the patiently hearing.
Thank you, ma'am, for such a wonderful talk. And I think we have a lot of questions pouring in, so I'll straight jump to the panel discussion. May I invite all the panelists to join in? So our next panel is going to be on enteral nutrition hypercatabolic state. Let me take this opportunity to introduce our esteemed panelists. We already heard Ms. Safala Mahadik, ma'am spoke about enteral nutrition in hypercatabolic state. Our next panelist is Ms. Harita Sham. She is a chief clinical nutritionist at Apollo Hospital and she specializes in disease-specific nutrition advice for diabetes and weight loss. She holds a master's degree in nutrition and dietetics and a PG in preventive and promotive healthcare. She's a faculty and course coordinator at Apollo's School of Nursing. She has several publications to her credit, and she's guided over 200 students for internship. Our next panelist is Dr. N.M. Sanjaya Hettigedara. Sir is from Sri Lanka and he has over 35 years of experience in the hospital and community pharmacy. He is currently associated with Ceylon University. He's a pharmacist, registered pharmacist, as well as has a certificate of proficiency as a dietitian, which is issued by the Ceylon Medical College Council, and he's registered as a nutritionist by Sri Lanka Medical Council. He has a PhD and also a master's degree in science, in food science and nutrition. And he also has experience in public health and principles of food science as well. Welcome, sir. Our next panelist is Ms. Vedula Champa Mazumdar. Ma'am has a master's in food and nutrition and she is the chief clinical dietitian at Apollo Hospitals, Bilaspur, Chhattisgarh. She's a former president of IDA Chhattisgarh chapter. She has over 26 years of rich experience in clinical nutrition in multi-specialty hospitals. And one of her achievements is researches in clinical nutrition with Nutrition Day Worldwide Project. And it received benchmarking in nephrology, oncology, intensive care unit, and an international nutrition survey in ICU. She also has various posters and paper presentations to her credit. Welcome, ma'am. Our next speaker or panelist is HOD, Nutrition and Dietetics, School of Medicine, D.Y. Patil University, Ms. Datta Patel. Welcome, Ms. Datta. She's the Honorary National Treasurer of IPIN India Association for Parenteral and Enteral Nutrition. She's a joint program joint officer for Nutrition and Diabetes Core Group and an associate editor at Clinical Nutrition SPEN. She's also an editor member of D.Y. Patil Journal of Health Sciences, and she also has co-authored various chapters for national and international publications. She also holds a master's in food science and nutrition and MBA in education administration. Welcome all the panelists. We now begin with the panel discussion. May I request all panelists to switch on your cameras? So I think at the outset, I'll start with ma'am has covered about some of the tools that are used for nutritional assessment. But in your practice, what are the tools that you use? And what is your experience in terms of seeing malnutrition in patients with surgery? So if we can just go around, maybe we can start with Datta.
Good evening, everyone. Thank you so much, Ms. Safala, for such enlightening lecture and the presentation. As far as nutritional assessment is concerned, in my practice, we are using a modified version of SGA and NRS. So NRS give us a quick idea about the nutritional score of the patients, and further towards the SGA will give us an insight of spatially physical focused nutritional examination of the patient. So in our setup, we use the combination of NRS and SGA, and at times the GLIM criterion also. In my practice or in my experience, I have observed more of the patients who are coming for the major elective surgery. 60% patients are malnourished, and if we focused on the early nutritional care for all these patients, we can definitely overcome the recovery, the post-surgery complications like infection, sepsis, and any other complications, and improve on the nutritional status and the recovery of the patient if nutritional care is taken well care in advance.
Thank you, Ms. Datta. Ms. Harita, would you like to add?
Yeah. So ours is a tertiary care corporate sector. So we don't see 60 to 70% like Datta said. Ours is around 30-40% of the patients coming in probably on day one would be identified as either malnourished or at risk of malnutrition. But if these people undergo major surgeries, complicated surgeries, length of stay is greater than 5 days, that's when we have challenges of nutritional deterioration per se. As she mentioned, we also use a modified SGA format to understand the initial nutritional assessment of the patient, but it is a very day-to-day close monitoring for patients who undergo major surgeries and need any kind of a nutritional inputs, monitoring, intervention, and this is monitored on a day-to-day basis in terms of their electrolyte balances, in terms of their intake. While we cannot in a larger setup, we cannot look at nutritional intake of each and every patient, document it and calculate it. Patients who have undergone a major surgery, especially GI surgeries or oncosurgeries, where intake is compromised. Or, for example, as Safala ma'am has said, that in liver transplants, in those areas, intake is monitored on a day-to-day basis. And adequacy of intake also dictates whether the patient is moving from the ICU to the ward. This may not be for all the patients, but certain core patients, for example, BMT for liver transplant, the surgeon looks at the adequacy, takes a note from us and says that, yes, this patient is eating well. And that's when he is also feeling confident to move the patient from the ICU to the ward. And until discharge, takes a very close follow-up of the actual intake of the patient, which gives us the confidence, which gives us very good opportunity to do our interventions and ensure that nutritional status does not deteriorate during the stay of the hospital.
So one of the key aspects would be also collaborating with your fellow surgeons and other physicians to assess the patients as well. So as you rightly said, do we also have Ms. Champa on the panel? Would you like to add something?
Yeah, just whatever they have explained, that same we are also following in our setup. But it's mainly, I just want to focus on the SGA. So when we are doing the SGA, subjective global assessment Philippine, so that time we have to be my new generation who is coming up, so they have to be take care of the last 6 months patient weight loss or not. This we have to be confirmed with the patient or patient attender. Either if patients having any dietary problem, like patient taking food properly before coming in ICU, patient taken properly diet or not, or either not discontinuing the diet, either patient on liquid diet or solid diet, whatever details, and we have to take to support to calculate intervention to the patient. In the same time, any GI problem is there or not, nausea, either vomiting or diarrhea, this type things all happen or not in the last few days. In the same time, comorbidity problem, any diabetic or any heart patient problem is there or not. These all histories we have to take on this SGA. In the same time, functional movements, they are patient or bedridden or chair ridden. So these all once we are taking and we are doing the scoring, so we come to know patient is well nourished or underweight or moderate malnourished. So accordingly, we can go for the calculations of the calories and protein for the critical patients. And yes, definitely we have to do the nutrition screening also. In for that, we can easily we will talk. We can go for the ABCD. This method we have to be follow for the just like A. For the anthropometric, we have to go accordingly, height, weight accordingly, that we have to calculate. And the same time, our whatever the patient's biochemical reports, whatever is coming, that we have to go through. And clinical aspects, evolution, whatever it's coming in the reports, we have to update. And as Harita said, that we have to be touch with our consultant, especially our intensivist. So whatever their decisions and what we are taking details of that. So we go for accordingly. If investigations report is any fluctuating, it's a lower or it's not in the normal range. So accordingly, we have to change the restriction, or either to be keep touch with our intensivist, so that we have to accordingly we can go for that. And definitely it's a depend on diagnosis. We can go for the our nutrition score or nutrition assessment.
Thank you, ma'am, for your inputs. Dr. Hetika Gedara, would you like to add anything that you do differently in Sri Lanka, or do you have similar inputs as well?
Regard to
I-
the
yeah.
thank you very much for inviting today for the to be in the panel. And with regard to these post and pre-post operative patients, especially, is a we can see in after introduction of enhanced recovery after surgery plans protocols by the American Society of Recovery. Enhanced recovery, but that one changed a lot, but still in Sri Lanka we have major private hospitals. Those hospitals, they are following all these guidelines. I know my colleagues, they are doing very well. And at the same time, government hospitals at various levels, A, B, C, D lines, they have graded. And most of the hospitals, there are no dietitians at the moment. It's managed by medical professionals. At the same time, the few dietitians are available in the government sector. In the private sector, well occupied. And I'm also in one of the government hospital. And I'm as a dietitian, I'm taking all the decisions with regard to the nutrition aspects, not the physician or the surgeon. That is our. Then I have to do the assessment of the patient and the critical care and ventilated patients, all even other patients. Then at the same time, I have to plan out everything and give to them, even prescribing of vitamin or any supplementation. I have to do it. The medical professionals is not going to do that part. Therefore, I have a freedom to do that. Therefore, with these guidelines, with this introduction of guidelines, we can see there are 3 guidelines if you compare, because this is very difficult sometimes to get all these guidelines is based on evidence-based research, level 1, 2, 3, like that. But anyway, the clinical questions are there. Who is going to clinical screening? For that, SPEN is say yes, we have to do it. And ACS, American College of Surgeons, they say yes. American Society of Enhanced Recovery, they said yes. But for this RD consultation, the dietitian consultation for these patients, also in ICU, so critical patients, SPEN say no, not applicable. They have not given the due recognition for the dietitian. At the same time, ACS, American Society of Surgeons, American College of Surgeons, they have given clinical screening by the dietitian plus. And the association, American Society of Enhance also said the yes, we have to do it. And oral nutrition supplement at the same time, they said all 3 years except the SPEN. And immunonutrition only recommended for the malnourished patient undergoing major cancer patients, cancer surgery, and all the other societies say most of the states the yes. Therefore, very difficult
Sir, do
to
we follow
understand.
INAS protocol in Sri Lanka?
Yeah, actually, we don't have our own, but there's one protocol published by the College of Anesthesiologists in Sri Lanka. For that, we have to follow it. At least it is there. There are protocols that is developed by the College of Anesthetics. We can do it, but the main details we have to, as dietitians, we have to follow the evidence-based nutrition, basically.
Yeah. Ms. Datta, do you follow ERAS protocol in your setup? Since you're from a government setup, do you follow ERAS protocol at all? Is there a scope of doing that? And this
In
question
our
from the
hospital,
audience.
because we are a charity setup, there is no complete set protocol that all the patients who are going under the surgery has to go to the ERAS protocol. But yeah, there are we have a different units of the, because it's a teaching hospital also. So there are some units which do consult us before if patient is going for any major surgery. So they do send for the nutritional fitness for the to the patient. So it depends on the unit to unit or the consultant, but there is no set protocol of following ERAS for the surgery as such.
How about you, Ms. Harita? Do you follow ERAS protocol for all surgeries, or is there any specific surgery type where you feel that ERAS protocol would be more applicable or more beneficial for the patients?
We also do not have any set protocol. It's very individual, surgeon-specific referral. Neither do we have a particular condition or a particular surgery category in which it is increasingly being asked for. So, you know, you always have guidelines, you have protocols, but not all are implemented in all the setups. So we are yet to kind of give it a very clear structure. Of course, there is focus on not to keep the patient NBM for long period before the surgery. But then, as Safal ma'am said, literally 2 to 3 hours before a surgery, that's not yet there.
Right. Okay. So, ma'am, just because there are a few questions, Safal ma'am, if you can just elaborate on, simply put, what exactly is ERAS protocol? Because there are still a few questions from the participants and they are not too clear about. So, simply put, what would be an ERAS protocol?
See, ERAS protocol too, because there are many aspects in ERAS. It's difficult to cover in just 2 lines, you know. But as I said, it is a psychological also aspect is covered. Exercise, rehabilitation also checked, along with the drugs also seen. But as just now I said about carb loading, which is considered as a nutrition aspect, I would say more emphasize. And nowadays in some units of our hospital, they have started. At present, they are doing some studies also related to 2 hours before, till 2 hours to give clear fluids, especially maltodextrines, and check. This studies also are going on, and especially anesthesiology department has started with this surgeries. For some elective surgeries, they have started with this, but it depends again, as I said, as Arita said, and this one, it depends on units to units. Somewhere ERA protocols are not followed, somewhere it is followed partly, then it depends. But of course, whatever said and done, we need to go ahead with the at least nutrition aspect as far as is considered. We have to see if the patient is very much malnourished prior to surgery, then definitely referrals will be there. And as I'm talking about cardiology unit, as I'm working there, every patient pre-surgery is sent to dietitian for the assessment, because mostly they are malnourished. As I'm talking more about valve surgery cases we see, and congenital heart disease cases in children. So we look after those in detail.
Most of the speakers and panelists have been saying for the last couple of sessions that guidelines are there, but what is applicable for your setting, you would have to decide.
Yeah, true, because guidelines are there to just guide us. Every time, not possible in practical setup to go as per exactly after guidelines. But yes, whatever, see, if we are calculation as the guidelines says, 25 to 30 kilocalorie per kg body weight or proteins, this much, and we try to maintain that. See, and first target, we cannot reach a specific goal. Slowly, steadily, within 2 to 4 days might take time till you reach a target goal. So it depends on the condition.
Yeah. Ms. Champa, what are some of the benefits that you've seen of ERAS protocol in your setup, specifically when, pre, peri, and post-operative, the patient is given nutritional support?
Yeah, there is a lot of our benefits are there in the ERAS protocol. So first of all, length of stay is decreasing, and same time patient's pain and need for the analgesia, this is also decreased, and same time patient's bowel functions also, it's improved when we are following the ERAS protocol. In the patient satisfaction also there, patients recover fast. So these all, it's observed that we have readmission rates also. These all are somewhere it is affecting if we are following the ERAS protocol.
Yeah. So I think since Safal ma'am mentioned about congenital heart disease, there's one question here. In children with congenital heart disease, patients usually are underweight and malnourished. So do we need to correct their nutritional status pre-surgery? How can the treatment outcomes be improved with the help of diet?
Yeah, it's a very good question. Really, it is needed. See, congenital heart surgeries, there are two types. Sometimes you get acyanotic lesions, sometimes cyanotic lesions. Like there are, for example, ventricle separated defect or PD or atrial separated defect, where they are malnourished. So muscle wasting and stunting both are seen in the pre-surgery in these children. So there are no specific RDA cannot be followed for this condition. Because all the even guidelines says that normally up to 1.52 gram per kg body weight. No, sometimes even we have to go ahead of that, from 1.5 to even sometimes 4 to 4.5 gram per kg body weight also given, because they are extremely malnourished. And the thing what happens is in various there is lung and heart function is the circulation is compromised. So what happens is there is so much of dyspnea and congestion in the heart. So they go on, they have frequent respiratory infections. So usually they have so much of myth in our rural or even urban areas that they link with this all specific food groups with that. And then before coming to hospital, they have already stopped, or because of myth, they have already stopped various food groups, saying that that will be having creating cough, or will have more impact on this. So we need to clear out their myths from the mind and all wrong concepts. This is a mechanical problem which happened because of very simple way, the hole in the heart, according to their language, what I say. So then we need to tell them this is because of that happening. Don't unnecessarily stop high biological value proteins and good qualities. And for example, milk, they will say that milk is causing cough, or dal will be creating a problem in this thing. So they already stop and come back. So we need to assess and counsel them almost regularly every day. They are not scared of eating biscuits, but they are scared of eating some good quality proteins. That also we see the picture.
Do you aim for weight gain in these patients?
Yes, definitely. See, pre-surgical, you will not find so much of weight gain until that congenital heart this is repaired. After the intracardiac repair, definitely we see a dramatic change in their weight gain, and muscle wasting also is stopped. But then before that, we need to give them proper nutrition so that they sustain that major surgery in this course.
Okay. Thank you, ma'am. So from congenital, let me come to adult cardiac surgery. Ms. Champa, in major CABG surgeries, patients usually are on an oral diet. Is supplementation really necessary? And which are some of the supplements that you recommend for these patients?
Yeah, this is for the CABG patients. Generally, we have observed that in our setup that they're having some lot of GI problems. Sometimes they are not properly digested because itself cardiac medicine, it's a gastric formation is there. So patients is not always feel some heaviness. So in that we have to be regular basis. We have to go and intervention on that key what patients are taking in the regular basis, and accordingly we have to be decide that patients requirement, as Safala madam also said, that 25 to 35 kilocalorie per kg body weight we are suggesting, and we are calculating and providing to the patient. And same time in the proteins, we'll talk about the protein. So we start 1.3 to 1.5 gram. If it is patient is digest properly, then we slowly increasing more. If it is patient is malnourished, then we have to give 2.5 gram per kg body weight. And same time we have to be observed that patient is properly tolerate or not, digestion is properly it's going or not. If patient is not tolerating, if refusing to take that, not whatever that we have goal not achieving, patient not taking that much. So in that part we have to to be take support from the formula feed or glutamine. We have to be suggest to them. In the formula feed, we have, as said, that polymeric is okay, but sometimes its observation is there. So polymeric, sometimes patient is not digest on that time. So sometimes we are go for the semi-elemental also. So for that, we have 3 days. Once improved GI, then we have to switch on to the polymeric. But same time, we have to be taken care and keep observation that patient's tolerance, patient's digestibility, and patient's response of the food, so that whatever the requirement of the after CABG surgery, so patient should be fulfill a complete diet should be taken, either oral or either use of the formula foods.
Thank you, ma'am.
I would like to add to this because in my setup also we have a lot of CABG patients, and I feel any surgery will initiate that inflammatory cascade in the patients. Now this inflammatory cascade will again increase that hypercatabolic or metabolic state of the patient, which ultimately increase the expenditure. Now most of the CABG patients are on oral diet, but if you see a traditional hospital diet is usually providing 45 to 50 grams of protein and 1400 to 1500 calories in a day. In that also, if that patient is consuming 100% of whatever breakfast, lunch, dinner, in between meals you are sending, and patient is completing that entire meal. So in my setup, along with if patient is still oral diet, then also we take the support of oral nutrition solutions. So at least 15 to 20 grams or 15 to 25 grams of protein we try to provide through ONS. So we ensure that that much grams of protein is going first class quality of protein, and then we add eggs and all that in the patient's diet. And also calorie is not more of my concern if patient's nutritional score is well fed, but protein is always emphasized. Even patient's nutritional score is not malnourished or not at the risk, then also we focus more that they fulfill 100% of protein requirement, and calories can be as per the requirement of the patient. We do not aggressively feed on the meeting the calorie intake on first day or second day or third day, but yes, by the end of the first week we make sure that they are receiving 100% of that caloric requirement.
So do you intend to use more of polymeric formulas, or do you use high calorie, high protein formulas for such?
No, standard polymeric formula if patient is tolerating well. If patient is not tolerating because of any of the other gastric issues, as Ms. Champa correctly mentioned, then we think of any other oligomeric formula, monomeric or semi-elemental formula, but to start with a standard polymeric formula.
So there is some evidence on CABG patients receiving glutamine supplementation and enhanced recovery post CABG. So what is your opinion? You know, it's open to all the panelists, whoever wishes to take it.
Yeah.
Yeah. Yes, sir.
Yeah. Actually, now all these contain especially in immune nutrition formulas. Those formulas contain actually all these glutamine and all these omega-3 and all these things added to that, maybe selenium, antioxidants and everything. But specifically certain guidelines says that is we have to keep immune enhancing the type of formulas, glutamine, and also especially head and neck cancer patients. And we should not give all the patients this type of thing. Initially, we should start the standard formula, and there, because while we agree with the SPEN and the strong support for surgical patients and the ACE are recommendations, we agree, but according to the literature, we can see this addition because of the added other immunonutrition formulas ingredients into the this modulate immune nutrition products. The only trial specifically for use in trial for ERAS, and at the same time data on immune nutrition in other populations, surgical and critical cares, are not done basically. There and some data is not there for, there's a harmful for certain populations, and certain use of the ink cost is very high. And based on that, I think dietitian has to decide what to give it. Although it's a guideline says dietitian's clinical judgment is very, very essential to prescribe these modulators.
Yeah, thank you.
Yeah. Can
So-
I say something, Sukada?
Yes,
Yeah,
ma'am.
sir, rightly said. Our dietitian clinical judgment matters a lot. See, in various surgery, depends upon the type of surgery where has to be used. But I would say that glutamine is not necessary that we have to use in surgeries. First, acute stages, post-operatively, in first few days, we should go for this high calorie, high protein formulas. You know, that works good. And otherwise, primary formulas, according to surgery type, we can decide that. Glutamine comes after, you know, when where there is an intestinal permeability problem or gut barrier is getting affected, or where immune function is compromised, and all this. And along with that, same time, your renal and renal function, liver function is intact. And then we can think about giving glutamine. Otherwise, is not routine use of glutamine supplementation is not needed as such in many of surgery conditions. Especially a major cancer surgeries, it will have definitely good impact.
Yeah. So on this note, ma'am, a lot of the there has been guidelines also where there's strong recommendation for immune modulating formulas with arginine, omega-3 fatty acids, and ribonucleic acid. But there is still an 11% of the
Yes.
policymakers that feel that there is a concern of using immunomodulating formulas. In your experience in cancer surgeries, particularly major cancer surgery and head and neck cancer surgery patients, do you see benefit of immunonutrition formulas? And if at all there are any concerns, what are your concerns? Anybody?
Yeah.
It's open to all.
Yeah. Actually, for the head and neck cancer surgery patients, these immune nutrition formulas is very useful. Not other things, because we have to reserve for that particular group population, because there's no trials, correct trials and the correct dose of these particular immune nutrition products. Therefore, I think this is very correct. We have to give a key for the cancer patients and cancer surgery patient. Other patients, dietitian has to determine whether to give or not. Otherwise, unnecessary load of glutamine, arginine, antioxidant, and so many things added formula is given. Therefore, standard polymeric formula is the best first. Then we have to initiate it, even the liver patients. We have to initiate it with that. Otherwise, unnecessary load of BACC is going branch in amino acid also. Therefore, I think we have to that is all depend on the dietitian's scientific knowledge.
Yeah. So renal function and liver function needs to be assessed if at all you're using an immune modulating formula. And it's also important to judiciously use at the right for the right patient, and not unnecessarily use it for all the patients. So that's the take message I see from you.
I would like to add on to this about using immunonutrition. So if you see the patients who are severely malnourished, or who has a NRS score or the very poor scores of the nutritional status, then we suggest using of such immunonutrition like omega-3 fatty acids, oral glutamine. But as you say, the guideline says, and in the current IAP in India guidelines presented for the head and neck cancer, even they says that there is no consensus for the starting immunonutrition for all the patients randomly. So it also depends on the patient to patient, and also say that if you are using a disease specific formula like for cancer or something, most of them have the normal RDA of the micronutrient, right? So sometimes we also don't want to overboard it, unnecessarily give it to the patients. There are some patients who have a malabsorption or the gastric issues where they are not able to absorb, and in those patients we definitely recommend to start some of the immunonutritional additionally. But as guideline says, it's not for all the patients.
Yeah. So judiciously selecting your patients and selecting your formulas is extremely important. One of the questions in the audience also talks about albumin levels, and how relevant is albumin and pre-albumin. Although ma'am has covered that in her talk, but since that question has come up, most of the surgery patients will have poor albumin levels. So I think, Ms. Datta, if you can take this, how does that really impact clinical outcomes, and what can we do via MNT in order to improve the albumin levels? The
Right.
answer is
So
obvious, yet
basically, yeah.
it's to be reiterated.
Yeah. So poor albumin levels is always suggesting a poor clinical outcome. Right. And when this says mainly poor albumin status also suggests that the stress. So basically in surgery patient, there is a surgery related or a trauma related stress. So this stress will again increase your, catabolism by increasing your cortisol levels, increasing your uptake of your energy or your amino acids by glucagon uptake. Also, there is an insulin resistance because of that. So, poor albumin level will suggest that the patient is under that inflammatory cascade and the catabolism is high, hence the requirement is high. So, in that you have to give a high protein and high calorie formula, which will suffice the need of your higher catabolic state. And as earlier mentioned by Champaji, Safalaji, that if you are using a ERAS protocol, then in such patient using a ERAS protocol will definitely reduce your surgery-related stress and help to maintain at least your, hepatic glycogen stores, and you will see the less loss of lean muscle mass and improve more of the functional capacity in those patients. So my focus in the patients who have a lower albumin level is to feed them with a good amount of protein and the calories as per the requirement of the patient.
Yeah, that makes sense. And thank you so much for that answer.
Because albumin will take time, no, to show the reports. It will reflect after. But basically, when we see patient in front of you and clinically it is improving, so then also we come to know exactly, as Datta said, we need to use high calorie, high protein and other with high good protein formula, good combination. Definitely we see the improvements in this. So should not wait for levels.
Then actually with regard to this question, albumin is wrongly, most of them have taken as malnutrition marker. It is wrong, but it is very valuable for the critically ill patients to monitor with their prognosis and all. It is very, very important marker for that way. And at the same time, to prevent the low albumin levels, the ICU patients, most of the literature, evidence-based literature says, start even the SPAN and all, start the very correct amount of fat level, even a 35 to 40%. And at the same time, literature says high proteins containing products. So whatever the home kitchen made or normally the new regulations said always the commercially manufactured product. But whatever it is, we have to give the very high protein levels. Even sometime, even we have to go as one panelist said, so more than 2 gram per kilogram. Yes, we have to go for that level. At the same time, we have to correct from the fat, MCT or coconut oil or maybe olive oil or whatever it is. We have to give it the correct amount of energy from the fat. Then definitely we can recover the patient whatever it is. At the same time, coconut oil containing the more lauric acid and medium chain triglycerides compared to other things. Therefore, it is not go to the liver for metabolism. It's direct absorption to the cells and give the quick energy to the body. Therefore, maybe very pure virgin coconut oil or that type of thing is very good according to my experience that I'm saying.
Because it contains medium chain triglycerides, so that gives you readily available energy. I think my next question is to Ms. Harita, if you're still around, or any of the panelists can take it. The older ESPEN guidelines suggested that protein restriction for encephalopathy or in liver conditions, but more recently, the studies have shown that protein restriction in these patients can be counterproductive, and it does not really impact the encephalopathy grade. It may in fact worsen their clinical outcomes and their nutritional status. So how much protein to be given to these patients? What is your take on this?
Yeah, I think it's very clearly established now that even though there is, liver failure and certain degree of encephalopathy, we really do not restrict protein because this is a prolonged condition. And if you do restrict protein for patients who already have a challenge with protein synthesis, especially the minute proteins like albumin, they are unable to synthesize. They're always on the lower side. So if you further restrict, it is going to be counterproductive. Very clearly, giving 1 gram per kg body weight is a no-brainer. However, you may want to individually assess a patient's if you are monitoring the patient very closely, you would want to scale it up, but you would want to scale it up very slowly and very guardedly. See that their parameters are not improving and the patient responds very well. You can slowly go up. But anything below 1 gram per kg ideal body weight would be a crime, and therefore the concept is totally obsolete.
Yes. So when increasing,
actually, I want to add to that answer also. The branch chain, the branch chain amino acids formulation actually should be reserved for the rare encephalopathic patients, not for all the liver patients, chronic liver patients. Even for the end stage, we have to reserve for that patients and manageable that those patients with a standard treatment with antibiotics and lactulose. And that the way new criteria, I think, according to now the criteria, I mean the new research coming out with the evidence base, I think that's also we have to keep in mind, because we have misled with this BCAA for all liver patients. That is wrong. I think we have to initially start with the standard formulations for these patients with the, she said correctly, we have to give the correct amount of proteins to those patients. Then definitely we can recover. I have seen those patients, platelet levels is gradually increase, and even 24, 30, 32, like this is going up. At the same time, blood urea levels is very low levels is going up. Then blood urea nitrogen level is going up. Then in the reversing serum creatinine levels going up slowly, 0.62 above those patients. If you are giving the correct amount of proteins, then only we have to monitor the patient, the correct amount of protein needed to those patients.
Yeah. Thank you, sir, for that. Safala, ma'am, my next question is to you. Which are some of the GI surgeries where you would use semi-elemental formulas, and do polymeric formulas also work well in these conditions?
Yes, in GI surgery, people would say same small bowel resections. Their semi-elemental formulas will work better. That also depends on the previous acute stages, post-operatively immediate. First phase, we can go for the semi-elemental formula, which works good. Pancreatic surgeries, their semi-elemental formulas go better. But even, yes, polymeric formulas also I have seen. So it is very patient specific, and how the tolerance is and overall clinical condition, it depends on that. But we have used in various GI surgeries both ways. Even this semi-elemental formulas specifically in more malnourished and those have GI system is very much compromised. There we have used this semi-elemental formulas. Otherwise, we have used polymeric formulas in many conditions.
Many conditions. Okay. Ms. Sarita, what is your experience with semi-elemental formulas, particularly in DMT patients, since you have some expertise in that area? You're on mute. You're on mute.
Okay. So we do have a mixture of BMT patients. We do have a lot of gastro patients. If we've seen the patient earlier in the ward, if it's a known case where they have had compromises in GI tolerance, it is very clear that we go ahead straight and do a semi-elemental formula. No harm in doing it, especially those who have a highly compromised GI. As ma'am said, pancreatitis is a classic condition. Let's say it's an underlying known case of Crohn's and he's undergoing some kind of a resection. We would straight away at least start with semi-elemental based on tolerance. Once the patient's condition improves, we would also, slowly try and escalate if regular polymeric formulas might be tolerated. So it's not blanket rule for all ICU patients, but yes, for GI, that could be the first line of, supplementation that you would want to try if the patient is taking enteral, because I've seen even patients who are having pancreatitis, taking an oral diet, if you want to supplement them, they do not as much tolerate polymeric formulas, but they tolerate semi-elemental very well. BMT is also a similar condition where patients could land up with very high incidence of diarrhea, and they're also the patients where you would want them to absorb nutrients as much as possible and give as little rest the absorptive process as possible. Yes, these two are the conditions where we would consider giving a semi-elemental formula in addition to the regular liquids that we're giving and the other easily digested food if the patient is taking it orally.
Thank you for that. Since you're on the topic of diarrhea, often like this question has been coming right from the start. Drug-induced diarrhea is very common, in surgery patients or, in ICU patients. Would you stop feeding your patient if there is drug-induced diarrhea? I'm asking this question because there are a lot of students attending this session. So would you stop feeding the patient if there's drug-induced diarrhea?
We wouldn't stop feeding the patient. There are many steps to it. One is identify which of the drugs has a major side effect. Diarrhea is a major side effect. Look at whether the patient is getting enough fiber, especially soluble fiber. The third step would be to see if the patient is on any prokinetics. To begin with, stop those prokinetics. Bring it to the attention of the physician that one of the drugs could be causing it. So whether he would want to relook at the drug chart. From the dietary point of view, we as dietitians do not want to accept that it is because of the feed. In most cases, it is not because of the feed. It's well established that it is antibiotic-induced diarrhea, which causes diarrhea, especially in ICU. So usually we see that when you start with a polymeric feed, first couple of days, day 1, day 2, day 3 usually are fine. It's only towards the end of the week that the patient actually starts with, diarrheal episodes. So you're trying to escalate feeds, you're trying to reach goal calories, and then they have this episode and you're walking back. We don't stop feeds, but yes, there are methods of doing it. If you're giving bolus, you switch to continuous. If you're giving large volumes, you reduce and try and go, slow volumes or lesser volumes. And then on a day-to-day basis, try and increase the volume so that you can go back to full volumes as much as possible. If you've been doing a hypercaloric formula, we definitely stop the hypercaloric formula and try and go to something which is more isocaloric or semi-elemental so that it is more easily manageable. So there are various things to do, and therefore each patient could be a different case.
Yeah, I think I would agree 100% to what Haritha said, because it is very important to find out first the root cause of diarrhea. It's not always the feed which instigates the diarrhea. So identify if there is any drug associated with increasing this diarrhea. And when it comes to the feed at the end, we definitely taper from the hypercaloric to the isocaloric or hypocaloric formula. We change the maybe polymeric to the semi-elemental formula. We change from bolus to the continuous feeds. So stopping the feed is never the solution, rather than, feeding correct and feeding rightly. It's more important.
So what I understand is assessment is not just a one-time thing. You need to continuously keep assessing your patient and keep changing the treatment modality as and when required. Be it the kind of foods that you've prescribed or the calories and protein that you've prescribed, but also the types of formulas that you're going to use as well.
Even use of probiotic is also at help.
Yeah, I was going to tell just now the same. The use of probiotics along with the both. This other all comments there, Haritha and what Datta said is almost same, that we totally echo the same. These are the principles we need to follow, but no, never stop feeds. Even sometimes some we're using milk with some formulas. We will use it with the buttermilk with some supplementation. That way also we can change and see. Osmolality, yes, definitely we need to check along with this. So all the same aspects which are covered by both of them.
Yeah. Again, I would like to go around the entire panel and understand what are some of your favorite micronutrients that you use in surgery patients. that you specifically look for in the formulas. So there's one question which we'll take that question, and it is related to micronutrients. In liver transplant patients having magnesium deficiency, how do you correct it? I think he means to say, yeah, how do you correct it?
In my hospital, we do not, as a dietitian, we do not give any corrections for the magnesium, but usually we speak to the doctor, and usually it is medically managed by the giving magnesium salts through IV or by the doctors. I don't know about Harita and all, but in my hospital, we don't manage the magnesium deficiency. It's always from the medically managed.
In my hospital also, the IV magnesium injectables are given even for thiamine. Wherever required, they will be given IV through injectables. And also multivitamin and mineral supplementation goes on wherever required. Yeah. As dietary sources considered, then we will take care as we will progress towards diet, when we'll give him overall well balanced diet, and definitely we will take care of magnesium and other micronutrients as well through food.
Yeah. My experience is also similar, but apparently skin absorbable magnesium is now beginning to be available, and if that's so, we all can start looking at that one. Second, I had one case where patient was getting repeatedly readmitted since last June. I think that every 2 weeks and sometimes every 2 months he was in the hospital because of poor intakes, and every time he had low magnesium levels. So for while he was getting admitted and he was getting the general care, we never got a specific referral for this patient. But one day out of the blue, the nephrologist got this patient again in the ER, and he called me in the ER and he said, Harita, look at his nutritional status. This guy comes to the hospital every 2 weeks, and there is nothing much that we can do. It's only his nutrition which is a concern. So I did not sit up to correct the magnesium specifically, but I corrected the overall nutritional intake, counseled the patient, in fact, took the patient into confidence, because the specific detailing from the doctor was, he's not listening to me. I have told him repeatedly, now you take care. So after our consultation, it was very good, and patient did not get admitted for about 3 to 4 months now. I went back to the surgeon to understand, I went back to the nephrologist to understand whether he thinks it is because of improved nutritional intake, and he agreed to that. I spoke to the family also, because the family happens to be a colleague of mine, and we bump into each other very frequently. And they said their feedback was also that once intake improved, patients started taking regular diet more correctly, and the supplementation and is also more correctly, automatically everything around it improved, and without correction the magnesium itself improved as well. Otherwise he was getting admitted, getting an magnesium IV, etc. So I think if you correct the overall nutritional status, this also does get corrected, as Safala ma'am said. So yes, all of us need to start looking at magnesium more closely, which we have not. However, at the moment, it is more medically corrected.
It's actually vice versa also. Sometimes even I have seen such incidences where the protein albumin levels, even total serum protein albumin levels, is not coming up. The intake we are assessing regularly every day, because and then once I just we discussed and we said, okay, let's check the serum magnesium level. It was tremendously on lower side, because magnesium is a cofactor of our various amino acid synthesis, for various enzymatic reactions in the body. And when they had started with the magnesium supplementation was given, IV for only 1 dose was given, and then afterwards, and along with that, of course, nutrition was taken care by us. So in both ways, we need to see that when we give good protein, same time balanced diet, and this magnesium was given, and then we started improving on that. So that time they had to give magnesium through injectable, and then they started for supplementation. Magnical was given.
Yeah, I am understanding what you're saying, ma'am, and I kind of see what you're saying. But if the serum magnesium levels are not low, it would be hard to convince a intensivist or a physician to actually give magnesium supplementation, right? If it is low, they might agree.
Yeah, it was low. That's why they initiated.
Yeah, okay.
It depends on surgeon, you know, every perspective is different.
Yes, close observation also from the dietitian's point of view is extremely important. So the questions are still pouring in, but we can be here the whole night, but the panel has to come to an end. So one take-home message from all of you, and we'll end the panel on that note. Ms. Champa, would you like to start?
I think I start.
Yes, please.
So to all the fellow dietitians and all of us, it's very important first that you assess your patient, identify that what is the correct nutritional needs for your patient, and usually thought processes that we always think from where to feed. No, your first question is that what is the requirement, how much to feed, and now which route is available to feed. And practically all patients are going to be different and their requirement is going to be different. I know we all are, you know, some we have a burden of the staff, or, you know, we don't have enough time to spend after the patient, but you know, make friends with nursing staff also, that so you can, if you're not able to go for intake monitoring, when you go for the rounds, they'll tell you, ma'am nahi khaya, आधा खाया है, कल का छोड़ दिया, दो feeds miss हो गए. And these things are very important because it is not only on the paper. Practically how much going to your patient and how you're going to fill that gap is very important. So I think feed value to your patients, identify how much you have to feed, and plan your target that, okay, first 2 days I'll try to feed at least 50 to 60% of the requirement. Then gradually I'll go to the 85. And by the end of the 4-5 day, I'll feed 100% of the requirement. That will be a message from my side.
Thank you so much.
Yeah, I want to conclude this. First of all dietitians who are upcoming, that dietitians, they should closely do the teamwork with your consultant, nurse, as well as your dietitian team with your F&B team, right? So once you will come patients, you have to go for the patient's nutrition screening first. As I told, A, B, C, I have to be maintained that anthropometric, biochemical reports, clinical, whatever the evaluation is there, that we have to go through that. Then you have to go for the diagnosis. Accordingly, you have to go for the SGA to just check patient is the well nourished or malnourished or moderate. So accordingly, you have to decide the calories, protein, whatever the requirement. Maybe it's a first day, it's not possible sometime for the achieve for that goal as per the requirement of the patient. But yes, still we have to be start as soon as possible within 24 hours to give the feeding, either oral or enteral feeding, so that patient should start that. If what in our setup practice, what we are doing, if patients, as per our guideline says that we have to start within 72 hours. Right now, this new update, that is 72 hours, we should, 48, within 48 hours, we have to start our feedings. If 48 hours is done, and doctor is not saying, not changing anything, NBM is continue, we should talk with our consultant. This is the practice we should do as a dietitian. We talk with our consultant, sir, this is patient is continuously 48 hours is going to be complete. So can we start? Maybe they have to be give the suggestions to you or advice that you can start clear liquid or either enteral feeding, whatever the RT. So you have to, in a small amount of feeding, you can start. Maybe it's a bolus feed, maybe it's a continuous feeding, that you have to be planned accordingly. This is your main part of the dietitian. And when we are talking about the intensivist in the ICU level talk, so that time we have to keep touch with our intensivist. And same time, as we have discussed that whatever the problems for the diarrhea and all, so we discuss with our consultant. We have to check the drug chart. It is any this correlation is there or not, if any food drug interaction is there or not. So that we have to check. If it is there, but continuously it is diarrhea is there. Another, as Safala said, that even if using the milk, then we have to go for buttermilk means curd form we can give in the kitchen feed if we are using the kitchen feed. But main thing is that whatever the handling the things in the kitchen, that hygiene point of they are following or not, that we should correct, we should check that. And how we will check? We should send our sample to microbiology lab. So that will come to know it is okay or not. So that is also one of the documentation that you have doing good practice as per the hygienic point of view. Also your F&B following for properly. If it is formula fit, then accordingly you have to be planned. So conclusion is that main thing is we have to do the teamwork, and with the closely we have to monitor with our consultant as well as with the nursing.
Thank you so
This
much.
is from my side. I can
Thank you so much.
conclude.
I've already summarized in my all the 3 surgery topics, so I would not say much. But then I strongly believe that dietitian should be a very well observer, good listener to the patient, and detailed nutrition assessment is a priority. Then, and which you will correlate with the many things, biochemical parameters, clinical relevance, medicines. But many of them, they need to see the drugs also. Drugs also has to be taken care, because many times they see the drugs are not taken into consideration while taking assessment. So you need to look at that also. So address all the perspectives, and of course multidisciplinary team works great. Then only we can go ahead with the positive outcome. So
thank you so much, ma'am. Ms. Sarita?
I think everybody has summed it up beautifully. Just like the recently concluded IAPN came up with a declaration, I really loved it, to say that medical diagnosis is incomplete without a nutritional diagnosis. So if we can keep that in mind, spread that information, get the entire DTR team to believe that, nothing like it.
That's great. Thank you so much for that. And last but not the least, Dr. Hypercalemia.
Yeah, actually, almost all the panelists said what I want to tell you, but I want to add one thing. The dietitian also should know how to interpret the biochemical data, correlate with other parameters, the assessment data. This is very important. Sometimes with the reverse way, sometimes the negative way, positive. As example, say if you're going to interpret certain report set, we are evaluating for the renal diseases, maybe higher side for those renal profile. For the liver side, it is for the lower side. Therefore, we have to balance this and see where we are. Like that, almost all the patients, we have to see the biochemical data reports in addition to all these speakers. I agree with that. That's my conclusion. And read the knowledge. Don't depend on just the guidelines. You have to go for the beyond the guidelines and use your clinical judgment. And with that, I think we have to use the level 1, level 2 research base, evidence base. From that you use. If you have a clinical problem, the problem arises during this visit to your patients, very difficult situation, then go for the case studies, for the very acceptable case studies even. You can get solved most of the problems, I think, as a dietitians.
Thank you so much, sir, for that comprehensive summary. So I think I would really like to thank all the panelists for your valuable time. One quick announcement and then we can end the panel. So all the participants, feedback link is there in the chat box. It will not be emailed to you. So feedback link for all the 5 sessions has been kept in the chat box. We'll see you next week on a session on enteral nutrition for cancer. So kindly please join at 6:50 so that we can start the session at 7 o'clock. Thank you so much. Have a good night.